Welcome to Primary Care Conversations with Christine and Jeff, providing valuable and engaging pearls of wisdom on a broad range of topics relevant to your practice. Now join your hosts, Dr. Christine Palmay and Dr. Jeffrey Habert, as they guide you through the ever-evolving world of primary care.
Welcome, everyone. Thanks for joining us today. Our first live podcast. Nice to see you in person.
I can't believe on the final day of a conference on a Friday, you have a turnout. I'm going to pretend it's us and not the breakfast, but we're really excited to have you here. And hopefully we won't be canceled because that seems to be the theme this week.
And it's welcome.
Thank you. Thank you for having me.
We're so happy to have you. And for us, it's interesting because usually we're taping in my basement. I record these and today we have to be fully dressed. It's a whole different adventure.
Yeah, you have to have pants on today.
Right,
yeah.
Exactly.
Which is a good
so we're
thing.
looking forward to it. So our first topic today, and we have you two as experts. I'm just going to moderate this. We're going to actually be recording two podcasts today. That's why I say first topic. So this podcast, we're going to discuss contraception. And I'm going to moderate for you two experts. So we're going to talk about contraception. And I know we talked about it a little bit. And we talk about contraception through the ages. So let's start where we should normally start, young. So we have the 16-year-old female that comes into our office and we've known her for a long time and she's probably coming in without her mom and she's saying she needs to go on contraception for maybe she's going to come in and not admit to being sexually active, or maybe she isn't sexually active, but let's assume she's sexually active. She needs contraception. The options have changed dramatically. So if 10 years ago, we would jump to the birth control pill, and now we have many options. So where do you guys go with this?
Yeah, I mean, I think when I speak about contraception in general, I mentioned that, we live in a really exciting time right now. There is a renaissance in women's health. And up until a few years ago, the contraceptive landscape was kind of static. We didn't have any newcomers. And then we have newer options. We have Nexaplon, implantable. We have a new progesterone-only pill called Slind. We have a newer combined oral contraceptive called Nextstellis, which is a game changer because it's a different type of estrogen instead of ethinyl estradiol or ezetrol. So the options are quite diverse. And, if you're thinking about your younger patient, I think the patient is probably going to come and ask for a pill, right? That's what she knows. She's seen the LS advertisements on the TTC. And probably that's what you're going to end up giving her, some version of a combined oral contraceptive pill, as long as she can take one and no contraindications. But I really think it's also important to pause and sort of say, let's back up a bit and talk about other options that are available. And if you look at the SOGC guidelines, IUDs are recommended as first-line options if fitting to a patient. I think the deficit with that patient population is a lack of knowledge and just going, with what they know, what their friends on, what Instagram tells them to take or not take. And a lot of myths too. So I also see the opposite where young patients, and I'm going to say, I'm dating myself, young is let's say under 25-ish. They're scared of birth control because it's going to cause them to be infertile. Or Lauren told me it's going to change the way they pick their partners. Right. So a lot of myth busting has to happen. And I think that's relatively new. That's my general approach. And in terms of options, and Lauren, you can pipe in, bone development in general, and it differs if you ask gynecologists or endocrinologists, nobody can actually agree. We worry about allowing the patient to reach her peak bone mass. And we suspect that, if you are under 24, you need a pill with a bit higher estrogen. So, some of our go-tos may not be ideal. But really, the landscape's open, and I don't think you can pigeonhole a patient just based on age. I mean, perhaps she doesn't want an IUD because she hasn't been sexually active or is thinking about becoming sexually active, but I still present the palette of options and let them decide and then update them every 2 years.
So I'll tell you, Lauren, the problem I would have, and I'm sure you face it, and maybe you can help me with this, is they'll come in asking for contraception, as Christine said, usually the pill, and I'll start talking about the other options. But I find they're not there. They're shutting me down. They're not listening. They want the pill. And I would like to talk about an IUD, IUS. I'd like to talk about Nexaplon. And there's other options. There's rings. So how do you approach that when their focus is they want a pill because that's what they know?
For sure. I think that's changing. But when you tell them that like 50% of OCP users discontinue after 12 months, and if they want contraception for longer than that period, I find the SOGC counseling table where they can actually see the options and see typical use. So we don't ever look at the perfect use because we don't live in controlled trials. And they can see the rates of pregnancy with the option that they're thinking about. But I find like the health-seeking patient who's coming in before their sexual debut is quite rare. So I'll see patients after an unplanned pregnancy, so they're very motivated for a highly effective form of contraception. And we also know that we're using LARCs off-label in patients that are under 18, but telling them the SOGC and the Canadian Pediatric Society really support that practice. And sometimes it's showing them a tactile example so they can see what it looks like, explain the procedure. And, that's a counseling appointment, bringing them back when they're ready, but of course, giving them a pill. So the 30 milligrams of ethinyl estradiol or the estetrol pill is a great option in the interim, but they tend not to continue with those.
Sexual debut. I'm going to steal that.
I love that.
I didn't come
That
up
is
with
my
it. I
favorite
heard
line
it
of the
once,
day.
and now I'm pandering it everywhere.
I-
Oh my God.
I wouldn't say debut in my like a debutante pop.
That is the greatest term I've
totally
ever heard.
using
I was
that.
singing the same thing.
Right. Yeah. I mean, ultimately, right? And I mean, yeah, that 16-year-old's probably going to leave with a prescription with some sort of pill. One thing that I did want to, and Jeff speaks prolifically in this area, is talk about generics. I think there's a place, obviously, for generics. Poverty is real, and I'm not suggesting it isn't an issue for finances are concerning, especially now. But there are options with copay cards. And I'm only on this bandwagon because yesterday my sister went to fill a prescription and she didn't know there was a copay card and she had to pay $200. And I think we have to also educate patients that, we have some options that don't have generics. So oddly, Linessa still doesn't have a generic option, so you know what they're getting. Can we take a moment to talk about Aless, which we all prescribe? There's multiple generics of Aless. So every time a patient goes and fills a prescription, 3-month interval, they get a different generic. So you can imagine how the deviation in the molecule happens, and you'd be surprised to see how generics are approved. They often don't take side effects into consideration, constituents, additives, so something's lactose-free, perhaps it's not. So take a moment just to think about that too when prescribing things to patients, because I generally like to know what a patient's getting. And, with birth control, NOACs, anti-epileptic drugs, I don't know what we want to add to this. I really want to know what you're taking because there's been some.
I mean, I talk a lot about generics and I have no problem with them because I think they're necessary in hypertension, lipids, sure, go to a generic. But you've mentioned, I mean, I have a list of 5, but the big ones for me, oral contraception, I'm not a big fan of generics. Bisphosphonates, definitely not a fan of generics. And the problem is, so generic Residronate, we'll talk about it. The adherence rate to generic Residronate is really, really, really low. And the other big one for me, and I'm a co-author of the Canadian Depression Guidelines, is generic antidepressants are a real problem if you're switching. So we talk about unplanned switches. I get that it's necessary if you're going to be on a generic Cipralex, that's fine, but you can't go from one brand this month to another brand the next month. And understanding Canada, you're looking at a pharmacokinetic difference of 80 to 120%. But we digress. We'll go back to contraception. I think for contraception, I'm a real big advocate of no sub for a birth control pill.
100%.
For sure. There's
copay
no
cards.
switching around. It's no sub.
So, and I also, your practice, at least to me, somewhat reflects your vintage. Never say old. You're an expensive vintage when you're old. And I've switched from the oral contraceptive to prenatal counseling to the throes of perimenopause when you're riding hormonal bronco. And we have some great options for those patients that are safer, right? God bless perimenopause. If you want an extensive list, consult Instagram. You'd be shocked what people are attributing. The take-home message is that, we have all these options and there's not one fit that's perfect for every patient, nor is there one fit that will carry that patient over the course of her life. Things change. Your university students who are traveling, perhaps, you maybe want a long-acting form. And I think it's really important to have check-ins. So in the case of contraception, if it ain't broke, you still may want to fix it because there may be better options. Truth disclosure, so I put in IUDs, no generics, by the way, yet, available. I do not insert Nexaplum, but I refer for those. And I think we have Lauren here because she does. And I want to take a moment to defer to you to sort of, for me, it's a hard uptake for my patients, partially because I don't think I insert. So maybe it's the presentation. But
For
how are
sure.
you counseling patients?
For sure.
Right? IUDs,
Yep.
I've got it, kind of figured that out. And by the time people get to perimenopause, they're like, just get rid of my period. And they don't really care. It's different with a younger patient population, right?
For sure. I present all LARCs at the same time.
Yeah.
So obviously pros and cons to both. Like, are they okay with bleeding? Do they not want to bleed? And that might lead you. Also, are they comfortable with a pelvic procedure? So again, if someone isn't having insertive intercourse and that's very off-putting to them, we can place something just below the skin in their arm. It's good for 3 years, so it doesn't have like the time commitment that other forms will have. And it's a very, very simple in-office procedure. So even if you're not a high-volume IUD inserter, access is better. I think it was Health Canada approved in May of 2020, which like we were all a little distracted at that time. So I think there wasn't a lot of patient-facing information. So when I would talk about it back then, patients didn't know what I was talking about. Now they know, maybe their friend has one. So there's a bit more uptake. But very simple procedure. Bleeding can be an issue with any form of hormonal contraception. We know that. So getting ahead of it, giving them guidance about what their bleeding pattern might be. And what I would say for anyone with hormonal contraception or IUDs, treat the bleeding. So I like to do like with like. So if someone is getting an implant, considering putting them on a comparable progesterone like Marvelon for 3 cycles, just to stabilize the endometrium, TXA, NSAIDs. So other than them coming in and say, I'm miserable, get it out right now, and then being at risk for an unplanned pregnancy.
Yeah, and it's funny. I mean, I first actually saw one about 12 years ago. They're prolific in Europe, and a person came in. I'm like, what is that? I don't know what to do with that. But now it's becoming definitely more common. And I think the younger generation has a different perspective. And we're kind of segueing away from pelvic exams that are regular and less needed. We're going to have DIY HPV testing available soon, which is crazy to think. So originally I was like, I have to do pelvic exams on patients at any point, because at some point, if a woman's sexually active, we need to do a pap smear. And that's completely changing now, right? Because HPV self-swabs are coming up. So I think moving with the times is also really important, right?
Okay, 2 patients we definitely need to talk about before we finish this. The one patient, the 36-year-old smoker. What are we doing with her?
She's allowed to not be pregnant. You always, I know, but it's funny when we talk about the risks, you always
Right.
have
But
to
she can't take Tylenol.
Shots fired. Well, she's not pregnant yet. So you have to think about the risk with any form of contraception versus the risk of pregnancy. And the risks in pregnancy of clots and things like that are always exponentially higher. So the lesser of 2 evils is still less evil. And if someone wants to not be pregnant, then I support that choice.
Would you start on a birth control pill?
So I don't know that I would start with a birth control
Right.
pill, but if that's what they want, then I would go to the ones that have the lower VTE risk, which is our estradiol containing
Yep.
OCP. So there are choices, but I think we get so fixed in like, oh, you can't have
Right.
this. And to get away from that kind of frame of mind and just offer patients choices. But I would definitely start by recommending something that does not contain estrogen.
So I think the full extent of my practice is in perimenopause at this moment. So that's a very classic patient. There's 2 other options that are newer, much like the Nexaplon. And as I mentioned, Nextstellis. We suspect, contraindications are contraindications. You can't be fancy-free. It's funny, the smoking, actually look up the smoking guidelines because it's not so black and white. You have to take the patient contextually. And yes, she needs contraception and she deserves it if she can take it. But I really use Nextstellis quite often, right? Because of the novel estrogen, and it works just really well. Has been a game changer. And that would be a patient that I'd, talk about an implant to too. Perfect candidate that way. Having said that, sometimes I think there's the assumption that progesterone does not have thromboembolic potential. It does, right? So you still have to provide the counseling. And the other clinical pro, I'm just on the throes of coming back from the Canadian Menopause Society conference. Contraindications to birth control are different than for menopause hormonal therapy. Another talk for another day, but that was a bit of a clinical pro that came out. A lot of people asked me those questions during the sessions. So
I agree with you. I mean, so they're 36, they smoke. It would make me very nervous, and I would really want to push toward the other options. But if they really push, they certainly deserve a right not to be pregnant. I would be documenting that every
Right, for sure.
single year that I saw them,
Right.
because it would really, and you repetitively should document that in case something were going to happen. Okay, the patient that I think we do need to talk about, because it's getting, and certainly the 45-year-old or 47-year-old perimenopausal patient deserves not to be pregnant if she doesn't want to be. I like that. And certainly we get these surprises, 51-year-olds, 50-year-olds. I've had plenty of those. What do we do? She's 48, actually freshly divorced in a new relationship, hasn't used contraception in years, does not smoke. What do you want to do?
It's a pretty similar patient, right? So again, what are these? You can take other things into
I
consideration.
think the point, though, is she can get pregnant.
She can't. Oh my gosh.
Right.
We don't want those. Those are not
Right.
fun surprises.
Right.
So also, like, what are her cycles like, right? What is her bleeding like? You want to take into consideration because she might want something that covers that profile as well. So the same thing, I would start with the progesterone-only options. And I also prescribe a lot of Nextstellis if they want an OCP, which has some vasomotor protection as well. But so consider she needs contraception is the biggest point, not menopause hormone therapy.
So once again, this patient, am I on? So this patient, classic in my practice, and this is my go-to. You put in an IU-DUS, right? That gets her through the time. It provides endometrial protection so that at some point she's probably transitioning into postmenopause. And in that case, you can slap on estrogen, barring not having any contraindications. That's a really nice sort of, you need immediate contraception because your ovaries are confused. They're retiring, but they can make a baby. Pick a side, please. But you need to give that contraceptive effect. And in general, the rule of thumb is a woman can actually get pregnant 2 years after her menstrual period. So you have to have that 2-year coverage. And what's nice about the IUS is that it actually gives you the endometrial protection that you need. And you can patch on, slap, a Divigel, the gel, you can do an estradiol. I think that that's a really nice equation. And I sort of frame it in, this is a celebratory moment when women spend the majority, in most cases of their life, after their last menstrual period. And we know we want to prepare for that. So be celebratory. They're not very happy when they come in, though.
So you use both?
Yeah.
Okay. And you do the same?
Yeah.
I would
Okay.
I would veer more towards an IUS.
Okay.
Right? Just because of the possibility of, leaving it in, providing protection, and then giving estrogen later on.
Okay. So one more practical question. The female that's now 51 and she's on using LARC, she wants to know, am I menopausal yet? Do I really need this? What do they do? What's your advice?
Does it really matter? I know
100%.
when people come in and they're like, I want my blood work checked, I want these things. So we're really, I think, now focusing on symptom management and that being the focus as opposed to a formal diagnosis. So again, I would just really focus on what the patient's symptoms are and treating those holistically as opposed to giving them like a definitive label.
There's no symptoms. She's just saying, you know what?
Well, good for her.
I've had this Kylena now for 4 years. I'm 52. Do I really need it?
We need to probably replace the Kylena in terms of efficacy if she's still in that, early menopause window. And you're going to make the most conservative choice. I'm going to offer her a Mirena instead. But, for the patients who insist to take out their IUD, they come back, they're like, put it back in, if they're not quite in the full postmenopausal state. And yeah, I think, it's confusing to patients because we like milestones. I became, and the verbiage is also confusing, postmenopausal on this day, or am I in perimenopause? And I look at them and I say, I don't know. Are you? Let's talk about your symptoms. People we're so hooked on having numbers, which we all know don't mean anything. I only do hormonal testing in 2 cases. Number 1, if I'm starting testosterone therapy, or number 2, if a patient is on menopause hormonal therapy and they're not responding, then we have to dig deep. And then, of course, premature ovarian failure, those are a little bit niche. But for the general woman who comes in, who's consulted TikTok, I need my hormones done, it's not evidence-based. It's clinical. And for that patient, you could take out the IUD, and if she's in the throes of early menopause, she's not going to be too happy. So generally speaking, I'm suggesting exchanging, right?
Okay, that's great. All right, guys, thank you. That was a lot of fun. Thanks, Christine. Thank you, Lauren, for joining us.
And thanks for
I
sharing your morning.
appreciate it. Everyone have a good day.